over the past 20, because they
And the more I think about it, I'm like, now that I'm in philanthropy,
Yep.
like Noble and Chicago. Yeah. So I mean, I was like, okay, I'll get like 2 big bags, I don't know, and then make it something I won't eat until I bring it back to the office. You know what I mean?
The business Chicago division, and make a killing on the business.
Maybe.
I've seen them.
I mean, I would go to Lincoln Park because
There you go.
I lived in my friend took me around looking at
Sound check. Brian Alston, remote attendees, can you hear me?
Yeah. Yeah. Can hear you, Judy.
Yes.
Okay, sorry about that problem. Technical difficulties. We will start from the beginning. Thank
Yeah,
you.
before we do, I would just ask that from the remote participants, do not hit the mute all button, because then we've got to go through this set of mechanics to get back up. So thank you for that. I'll turn it back over to Dr. Makaitis.
Thank you again, Chair Gauser. We will take it from the top. New leadership. Welcome to Audrey Tanksley, Chief Medical Officer, Managed Care, Sagar Shah, Physician Advisor, Medical Administration, Erin E. Tizen, Patient Safety Manager, and Tony Wormley Sr., Hospital Lieutenant Security. And our recognitions for this month, on October 28th, Cook County Health, UI Health, and UIC announced an expansion of our partnership to better serve patients, enhance medical education, and advance public health research. Congratulations to everyone involved. And congratulations to Cook County Health for earning reaccreditation in URAC Specialty Pharmacy. This recognition shows patients that our pharmacy adheres to the highest standards of quality. Congratulations, team, once again. Congratulations to our Stroger team for its redesignation as a primary stroke center by the Illinois Department of Public Health. This redesignation reflects the hospital's sustained excellence in rapid diagnosis, advanced treatment, and coordinated multidisciplinary care for patients experiencing stroke. Congratulations. Congratulations as well to Josune Iglesias for being recognized by the Illinois Northern Chapter of the American College of Physicians. Dr. Iglesias received the 2025 Illinois Northern Chapter Distinguished Medical Educator and Mentorship Award. This award honors a member who has demonstrated an enduring commitment to outstanding teaching and mentorship and sustained commitment to medical education and excellence in the practice of medicine. And I don't believe Dr. Iglesias was able to join us today. And congrats as well to certified hand therapist Laura Carlos for being recognized by the American Society of Hand Therapists with the Emerging Hand Therapist Award. The award recognizes the issues and achievements faced by certified hand therapists within the first 5 years of their initial certification as they begin their specialty career. Congratulations to Laura as well. I understand she couldn't be here either. That was it. Okay. We'll pass it back to you, Chair.
Thank you.
Thank you.
Thank you. Once again, congrats to all the awardees and to the county system. Thank you.
Chair Garza, we have another remote attendee, Director Ryder, just joined us.
Oh, excellent.
A motion.
So I'll need a motion to allow Director Ryder to participate in the board meeting, please, remotely. Thank you. Director Staines, a second? Oh, thank you. I have a first and a second. All in favor, say aye.
Aye.
Aye? Any opposed? Okay, the motion carries.
Thank you.
You're welcome.
Dr. Bot's here.
Madam Secretary, do we have any speakers registered to provide virtual or in-person testimony, or have any written testimony and to be included into the record?
We did not receive any registrations nor any written testimony, and council points out that we should, since we had the technical issue before, we should verify that the other remote attendees are connected. Director Bott, you are connected,
Here.
yes? Thank you. Director Webster-Cross?
Here.
Thank you very much. Sorry about that.
Okay, thank you. So we will move to item, 4A, the Board of Directors meeting minutes for September 26, 2025. I'll ask for a motion to accept those minutes, please.
So moved.
Second.
We have a first and second. Are there any corrections or comments about those minutes? Hearing none, all in favor?
Aye.
Any opposed? That motion carries. All right, so now we will move to the minutes of the October 17th, 2025 Audit and Compliance Committee meeting. I'll turn that over to my colleague, Director Joe Harrington.
Thank you, Chair. The Audit and Compliance Committee met on Friday, October 17th at 9 a.m.
committee's regular meeting schedule for 2026 has not been determined. However, it is expected that the committee will begin holding their quarterly meetings in January of 2026. Nicole Emerald, Chief Corporate Compliance and Privacy Officer, reviewed the report, which included information on the following subjects and proposed action items: review and approve Audit and Compliance Committee Charter, review and approve Compliance Steering Committee Charter. We received the following metrics: Systems Compliance Program, County Care Medicaid Health Plan Compliance Program and Recoveries, and National Compliance Week. The committee did go into closed session and receive a closed meeting report, but there is no plan to re-review that today in a closed meeting. So the minutes can be approved at this time.
Okay, so I'll ask for a motion to approve those meeting minutes.
So moved.
Second.
Thank you. Is there any discussion or corrections to the minutes? Hearing none, all those in favor, signal by saying aye.
Aye.
Any opposed? None, so that motion carries. Thank you, Director Harrington. And looks like we're going to stay with you in the absence of Vice Chair Lowry to take on the Managed Care Committee minutes from October 17, 2025.
Thank you.
Yes, sir.
The Managed Care Committee met on Friday, October 17th at 10 a.m. The committee's regular meeting schedule for 2026 has not been determined. However, it is expected that the committee will begin holding their quarterly meetings starting in January 2026. Aaron Galiner, Chief Administrative Officer of Health Plan Services, along with other staff, reviewed the report, which included information on the following subjects: health plan successes, health plan metrics, policy updates, health choice RFP update, and quality. If there are no questions or further discussion needed on this information, the minutes can be approved at this time.
Thank you, Director Harrington. I am looking for a motion to accept these minutes as well.
So moved.
Thank you. Is there a second?
Second.
Thank you for the second. Any discussion, corrections? Hearing none, all those in favor, signal by saying aye.
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 Thank you. Any opposed? The motion carries. We will move down to item 4D, Quality and Patient Safety Committee meeting minutes that took place. The meeting took place on October 17, 2025. And I'll turn it over to my colleague, Director Bott.
Thank you, Mr. Chair. Quality and Patient Safety Committee met on Friday, October 17th at 12 p.m. The committee approved the following action items, which are included in the minutes. Approved 3 Stroger Hospital Division Chair reappointments and 1 Stroger Hospital Division Chair initial appointment. Approved Stroger and Provident Hospital medical staff appointments, reappointments, changes. The committee received the following reports, which are included in the minutes: Operations Excellence Dashboard, Goals and Tactics, Quarterly Grievance and Patient Experience Report, Regulatory Report. The next meeting of the committee will be held on Friday, November 14th at 9 a.m. And apologies that couldn't be there in person today, and happy Halloween. If there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Thank you, Director Bob. So I'm looking for a motion to accept the Quality and Safety Committee meeting minutes from October 17, 2025. Is there a motion?
So moved.
Thank you. I have a first and second. Are there any corrections or discussion on those meeting minutes? Hearing none, all those in favor say aye.
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 Any opposed? Okay, that motion carries. Those minutes are approved. And now we will go to the Finance Committee meeting that took place on October 16, 2025. And that looks like that's you again, Director Harrington. Man, we're putting you to work this morning.
Right. The committee considered the following action items, which are included in the minutes. Conditionally approved 14 contracts and procurement items as amended. Request number 2 was withdrawn. Number 13 is pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. We also received and filed grant award-related items, as well as received and filed transfer of funds. There's some additional reports. We had a report on minority and women-owned business enterprise participation. That's our MWBE report. Report of one emergency purchase, report of August financials, monthly report on agency reduction plan. With regard to the MWBE report, which reflected data for the first 5 months of fiscal year 25, Vice Chair Lowry requested data on the first 5 months of fiscal year 2024 for comparison purposes, and I can say that we received that. You should have received that via an email. The next regular meeting of the Finance Committee is scheduled to be held on Thursday, November the 13th at 10 a.m. If there are no questions at this time, the minutes are presented for the board's approval.
Thank you, Director Harrington. I'll ask for a motion to accept the Finance Committee meeting minutes from October 16, 2025.
So moved.
Thank you. I have a first and a second. Is there any discussion or corrections on those minutes? Hearing none, all those in favor, signal by saying aye.
Aye.
Any opposed? No opposition. That motion carries. Thank you, Director Harrington. We'll move to item 5. Excuse me. Contracts and procurement items. Charles Jones. We have nothing to present on item 5. So we'll move to item 6, report from the chair, which is me. So I had an opportunity to attend the Cook County Board of Commissioners Finance Committee meeting a few days ago where Dr. Makaitis and Pam Katsaris and many of the staff in this room presented. And I couldn't be there for the whole presentation, but I thought you did an exceptional job presenting the budget for the upcoming year. And felt like it was a very well-considered budget in terms of things that are happening that are unpredictable and some things that are unfortunately predictable. So I just want to say that I was proud to sit along and observe the good work, and I thought the commissioners were obviously always very engaged, but also I thought they were appreciative of the good work of the county and its staff. So I just want to say thank you for that. That's my report. And I'll turn it back over to Dr. Makaitis to give a fuller report on the update on ARPA obligations and divisional report.
Well, thank you, Chair Garza. And just to respond to your very kind comments, it was certainly a team effort and lots of prep. And yeah, it's just congratulations to the entire team for the hard work and I think a very great success.
Yeah, well, I appreciated the handoff when questions came to certain areas and your team jumped right in and thought did very well with that whole process.
Yep, team sport.
So, yep.
Okay, so we have 3 items today. We have a strategic plan update, we have an ARPA update, and then we have our Providence team update. So I think, Debbie, we want to keep kind of Andrea's pieces together and then do Providence third? Is that okay? Okay.
Good morning.
Good morning.
I'm Andrea Gibson, Chief Strategy Officer. This is our slide that reports on what we've accomplished in the past month and some of the things that are coming soon. The biggest thing in my domain is that the strategic plan was approved by the county board last week, so with no changes or anything like that. So we'll be printing it officially and sharing that with the board and get ready for implementation. In anticipation of that, we've gone to the 4 pillars that you see here. As you recall, we moved from 7 to 4 in the last strategic plan. I'll highlight a few things on this document, but under quality, safety, and experience, we participated in a variety of health fairs, a breast cancer screening fair at Providence with County Care, and 24 other redetermination events. We also had a Walk with a Doc event at Englewood Health Center. CCDPH released a report on suicide prevention recommendations in suburban Cook County. Valet parking started at Providence October 1st. Under coming soon, under quality, we're working towards opening the dental clinic in Blue Island in 2026. Under workforce, we have finalized a draft of an agreement with UIC's College of Business to allow students to work on data projects in conjunction with our teams. So this agreement has a term of 5 years, and we're looking forward to gaining insights from this work. We also had 7 nursing externship students complete the 16-week program, and they're expected to graduate in December. We have this week, I think just on Monday, opened the Belmont Cragen Dental Clinic, which is a good milestone. We also, one of the other things I'll highlight under transformation and growth is that we completed a block scheduling plan to improve our OR utilization. Things that are coming soon, we're working on completing construction documents for the mail order pharmacy that will be opening at some point, constructed then opening. We're also, through CCDPH, working with the Chief Judge's Office to transition to help increase the amount of from-scratch cooking at the JTDC. That's through the Good Food Purchasing Act program. Under fiscal resilience, we held an inaugural Medicaid impact work group, which was a cross-sectional group of organizations working to come up with strategies to approach some of the changes in Medicaid. And with that, unless there are questions on that, we can go to ARPA. The ARPA update today is a little bit different. First of all, the careful reader of the ARPA update will see that the total number is different than what you've seen before. I've previously presented a total of $174 million. This is 182. The reason for the change is we included JTDC's ARPA program, which is technically part of the Chief Judge's award. So it was awarded to the Chief Judge and delegated some of the care coordination activities to us. But I'm including it here because we are going to talk about all of the programs that we're working on, and it's included there as well. So we're about dead even when we look at how much have we spent and how much is remaining to be spent. I will say that we have a number of invoices that are in process, and so we think that kind of undercounts how much we've actually, how many services have actually been rendered. So we are going to be, I'm going to be joined today by a few different colleagues to talk about kind of the programmatic impact of some of the ARPA programs. So we'll start with Shannon Andrews, who can come up, and then Dr. Joshi, and then Dr. Nutter, just to give you some insight into what we've done with the programs and what we're thinking right now in terms of sustainability.
I have a question, it's a quick question.
Yes.
What is OCI?
OCJ, it should be a J. It's Office of the Chief Judge.
That's what.
All right, with that, we can go to Shannon Andrews.
Good morning, Shannon Andrews, Chief Equity and Inclusion Officer. Waiting for the slide deck to advance, I think. Oh. Thank you, Debbie. So there are 2 programs that I'll be presenting on today. The first is Food as Medicine. This program, which, and I'm sorry, do you think that's you?
We do.
Am I too close? Sorry about that. Or we could blame Halloween. But our Food is Medicine program, the support that we got from ARPA allowed us to expand, and it's a very timely conversation in light of what's going on in the larger space of food insecurity. But the metrics that are worth highlighting, or that we'd like to highlight today here, is that since opening our Belmont Craving Food Pantry between the dates of October 2024 and September 2025, we have serviced 250 unique patient households, and that translates to roughly 16,604 pounds of food being distributed in a shorter period of time. That was our inaugural food pantry, if you will. The second food pantry site was opened in Providence earlier this year. Then during the time frame between July 2025 and September 2025, we have serviced 160 unique patient households. And then in addition to the food pantry work that we've done, we've been able to support a medically tailored meals program, which since its inception in October of 2024 through August of 2025, we have had 6,559 meals delivered. It is important to note that this work is done in partnership with a number of collaborations, but primarily we work very closely with the Greater Chicago Food Depository. They have been amazing partners. We have an agreement with them. They actually provide insight and access into a larger community of organizations where their primary focus and mission is food insecurity. It is a unique partnership and relationship in that it allows us to bring the unique point of entry for us as a healthcare system into that conversation. And that is where individuals come into the healthcare setting and their health is being in real time very directly impacted by food insecurity issues, looking at those issues that are placed in certain communities related to diabetes and hypertension and a number of other things. It allows us to connect them to not only the programming through our system, but to connect them to a larger ecosystem of food insecurity support. Based on the success that we've seen and the nature of that relationship, we are looking to expand the food pantry concept in a smaller, unique and different way to meet some of the needs of an additional clinic, which would be our Robbins Clinic. And as it notes on the slide deck here, for sustainability activities, we work closely with the larger system programs that are looking to lean into the 1145 waiver support. And as indicated here, we've been able to shift 4 of the ARPA positions to the health fund. Yes, sir.
What are the metrics?
Beyond the ones that I've shared, the other metrics that we are looking at are very specific to healthcare outcomes related to a number of individuals who participate at the site food pantries are referred by clinicians and or doctors, and we connect and we are looking at the metrics to see what, if in any, impact this additional support has with the specific healthcare measures that have been identified about the clinicians, and it varies. The 2 primary metrics that we're collecting and looking at are related specifically to diabetes and hypertension, but working with our clinicians, we've been able to identify a number of other areas that we have been able to add into the program. It also allows us to expand the scope of patients that are able to participate. I can certainly provide and or get information related to that. We are cautioned in terms of, in working with our dietitian and nutrition partners, that the way we review that data will not be, if you will, on a week-by-week basis, but rather over time. We are very sensitive to that. It could take a year or more to see and or make the correlation between the impact of the food pantry and other resources and/or prescriptives, if you will, that have been provided by those clinicians. So we are connected in through our EMR system in a limited scope in terms of being able to collect and pull data. And again, we do this in partnership and work very closely with clinical staff expertise.
So when would you expect to present some outcomes or some kind of report to let us know what's happening?
Certainly, to the extent we have numbers that reflect, quite frankly, from a month-to-month basis, but as it relates to looking at a holistic sort of analysis of it, we are still working through. We anticipate that by the end of the ARPA program, there will be numbers and results to report out in that way, but certainly prior to the end of the program, we are working with our clinical partners and the dietitians to identify, now that we have the information coming in and now that we've expanded sort of the footprint of this, how best to present that information. But I'm happy to provide what we have to date to this body.
Are you talking about providing data or some preliminary report that we have some idea of what's going on?
At this point, it would just be data.
That's data. Yeah, it'd be helpful if we could get some kind of, or at least a timeline from when we could have a clear analysis of what's happened moving forward, because that's invaluable information. If it takes a year, but it's important to know how long this process is going to take. And if they're preliminary results, I think we'd like to see the preliminary results.
Absolutely. Thank you.
Can I just ask a quick question too? Since I know we're still trying to spend down the ARPA dollars, why are we already shifting the positions to the health fund? Is it just because it's not, the positions are for a full year and the ARPA dollars don't last that much longer? Or I'm just curious of that.
Last year, anticipating the new administration, the county Halloween goes to the machine. The county's budget office made some changes in how we approach ARPA. They were concerned that the federal government might.
Can you please get closer to the microphone?
That the federal government might reclaim funds tied to personnel because of how the structure was written out. And so the county used those funds for things that were very clearly part of ARPA and we didn't think they would be questioned. And so this year, the personnel was refunded by the county corporate fund, and they used those, they used those funds for like revenue loss, which is a very clear part of ARPA.
Thanks.
Hi. The thing that concerns me about the program, I think we all know that it is very much needed. I'm not sure if the measurements will necessarily support what we know. By that I mean, it seems as though there needs to be a base created, and this is almost like research, because we got to understand the impact of it beyond our anecdotal thoughts. We need to understand, if we're looking at diabetes and high blood pressure, how does that number move for that control group that you have, that you are actually providing the service to, versus historical or something else? We've got to have some type of number to say, this money was spent in this way to improve the health of these people in this particular way, and this is how we know it did it, because they moved beyond the average or something. I'm not professing to know what should be the metrics, because I haven't looked at this area.
I will say that as a part of this proposal, we looked at models of where this is not unique to Cook County Health, the notion that there are social determinants of health that impact healthcare outcomes. And so to be clear, I don't think that we started from a space of that this program alone would impact numbers in that direct of a way. But we believe, and I think it's supported by the fact that this is something that's being considered as a part of, or that is a part of the 1115 waiver, is that it is critical that to the extent that access to food plays a part, it is not the part, and it is not something that's alone, but we are looking at, and based on other programs that exist, and based on the work that we're doing as a part of, we're actually a part of a larger work group connected to the 1115 waiver, that there's an argument to be made that people are more vested in taking their medication, coming into even the notion that people will come in more often for their readings and or to engage with their healthcare providers related to this, because it is also a point of entry for having access to food, that there's an argument to be made that these sorts of programs can be significant. And so I think one of the reasons that we were successful in receiving the money, one of the reasons that this work is considered a critical part of the waiver process is that it is not lost on anyone that it plays a role. And so to the extent that we're looking at the metrics and we are looking at it in a holistic way, that if there's an individual who is seeing healthcare benefits and or we're seeing a shift in the way their numbers and their outcomes are coming into the system, that when we look at it in a holistic way, that there are a number of things that might be impacting that work. And it's one of the reasons why we work so closely with the clinical teams as it relates to what is happening with this patient in totality and what is their engagement in the process of looking to impact the outcomes in a in a positive way, if you will. So we will be happy to, and to be clear, the way that we're looking at it and talking about it with clinicians is an expansion of what we committed to reporting out to for the ARPA program, because clearly we would have had to have identified some of those things to receive the money, but the baseline for the receipt of the money and the participation of success with this was to see an increased number of people being willing to, one of the pieces that we used to get all the time is when we ask these types of questions, if you don't have resources to help people with positive answers to are you food insecure, it's not a, why have the risk assessment if someone says to you, yes, I am concerned about where I will get food from in the coming week, and at best all you can do is point them to websites and or paperwork. So there is a theory and a piece of the premise that we have is that to the extent that people are willing to identify in that way because we have a robust system and or path towards providing them access either by way of our organization or by partner organizations, that there's a positive impact. But certainly we are working with those who are smarter than us in the program space to come up with and establish beyond the access, beyond the notion that this program and this money has helped to bring people into the fold in the conversation of it, that we're looking at it as sort of what you've outlined is sort of the next level of what success looks like with it.
Okay, and just to be clear, I am very much a proponent of social determinants of health, and I've been looking. But the only concern that I have is that in budget-tight times, if you're not able to specifically point to this impact and how it actually helped the cause of the organization, the program can get cut very easily. That's my big concern.
Agreed, and we completely are working towards, we appreciate and know uniquely that numbers matter and that the data is important, and it's one of the reasons why we're looking to see how we expand being able to document and or show success of the program. So we will certainly report back to you as it relates to how we're looking to elevate and or go to the next level of using the data for, not only because it's the right thing to do and it's good, but because the numbers support that. So thank you for that.
Thank you so much for explaining that part as well, too. And then a question regarding what we'll be managing and what we'll be noting in the data. Are we then looking at not only clinical but the social indicators and tracking that for these unique households served so that we might be able to see what correlations after 1 year may be related to either improvements, engagement, numbers related to diabetes or hypertension, so that we know that this is a multifactorial process? Are we looking at, has social services also been called? Has housing first or services also been called? So that we're addressing the multifactorial issues related to that, including the food insecurity part, so that you'll really be able to have good tracking for what correlations you may have for the improved outcomes after a year.
No, absolutely, and thank you for that, and it's a very good point. We work diligently with a number of folks, including our Cook County partners who were part of the process in being approved and receiving these dollars in terms of identifying metrics that, quite frankly, were aligned with the larger county's long-term equity roadmap plan. And so the types of questions and information and data that we're trying to collect does expand beyond just the obvious of how is this impacting a very specific healthcare outcome. I'd be more than happy to get a list of what those metrics are and what those data points are that we were able to outline, again, in partnership and with the leadership of the county in terms of thinking beyond the obvious metric impact. But thank you for bringing up that point, and I'll make certain that we share it to the larger group.
Thank you so much for that. And then additionally, given the fact that I guess as of tomorrow, we may be looking at additional issues related to the lack of SNAP services, do we or have you been able to sit as part of this to have a potential estimate of need for what may come related to pending loss of SNAP support in relating to food insecurity, or what may be part of the recent allocation from the governor to be able to help to supplement for that loss of SNAP, and how these ARPA or any other funds might be part of making sure that food insecurity doesn't particularly become more problematic now that we're not only getting colder but moving toward the holidays.
No, absolutely. We have been looking at this, and we're part of, as I mentioned earlier, a larger, again, ecosystem of county-wide, not just city and county, but regional-wide teams who are looking at how do we all support a network of larger support systems. Again, I can't say enough about the partnership with the Greater Chicago Food Depository. We have been on weekly, sometimes daily phone calls. We're probably at this point getting 5 to 10 emails a day related to what the work of the larger group of individuals who are doing everything from the advocacy, the fundraising, standing up more systems regionally based on what the numbers show us. And so I'll be honest with you, I think for us the biggest advantage is that we are uniquely keyed in and tuned in that when people come into our system who are facing enhanced issues and are related to this, is that we have direct access and or the ability to point them in the direction where the larger ecosystem is best equipped to address that. Very specifically, the Food Depository has committed to increased deliveries for us. We are certainly looking to where, right now, at both of our site locations, we are open 1 day a week. We are looking to see if there might be a need to support being open more than that. But the reality is that the Food Depository is looking at how to do that in its most efficient way. And so to the extent that they're able to look at a geographical location and say within that geographical location there are 4 different. I mean, like, this is the level of analysis that they're giving it in terms of, we believe that the best thing is for these 3 sites that are closest to this larger hub where we can be most efficient in either increasing our hours, increasing staff, having more support systems in place to support, and we believe that that's reasonable. This is how we're advising our partnerships to help guide that work. And so while it is certainly an option for us, the other thing I think that the group and team have been really sensitive to is beyond the SNAP loss benefits. There's the element of, in certain communities, fear of coming to those obvious sites or points of interest that might, the unintended impact is that it will have a negative impact on immigrant related issues. I'm speaking specifically of ICE. And so they have been really thoughtful about sort of a traveling model of ensuring that people have access and or things that are options to them. And that is in addition to all of the advocacy work that they're doing, all of the fundraising that they're doing. And so we are certainly uniquely situated and have given thought to what does increase interest and or participation in this program. But I do want to be clear that very specifically for the pantry sites and based on the funding source, and it's worth noting that the only way to participate in that food pantry is if you were referred for a clinical reason for that space. So we're always very mindful that if you're not a patient of Cook County, and if a doctor or a clinical staff person has not referred you to the program, we are not a traditional food pantry. But having said that, even prior to this issue, we were uniquely situated to have access to and to be able to support and redirect, quite frankly, in some instances where there were just people walking in off the street, like they're not a patient. The other thing that our partners at the clinic have been super, what we saw happen is people would hear about it, come in and say, I'm interested in this. They hadn't been in to see a clinician, and now they're connected to healthcare services. That was an unanticipated win. Suddenly now there are individuals where I haven't seen a doctor in a few years, but I heard you might have access to a food pantry. So we're really looking to be holistic and efficient about how we have touch points in this space. But we do anticipate that there could be our partners at the food depository, which is the source of the food for the pantries, are certainly we're tied to and in regular conversation with them about how we might be able to pivot, if you will.
Director Sorrell, just for numbers, there's 900,000 people in Cook County that receive SNAP benefits. We have compiled all staff communication that summarizes all the resources that'll be going out later today. It's going to be sent to all of you. Beyond the tactics that Shannon was talking about, kind of all of the community resources so that our teams feel a little bit more informed. We'll share that with all of you, and then we're also going to share with the commissioners as well. And to your points about the data that is multifactorial, as Shannon mentioned. A lot of different pieces to it. We are going to try to tease apart all of those, but obviously at the end of the day, are we moving A1C? Are we improving, right, our blood pressure, rates more controlled? That's obviously the key output that we're going to look at.
You also mentioned something that I had written down, the geographic identifier. If you can get down to the 4-digit identifier, that would actually give you a lot of data, because now you can say those families that have this type of demographics in this particular area that did not actually attend or get to the pantry, let's make that comparison and see how we're doing from a health standpoint. What is the impact that they're having? Are they higher diabetes cases, higher blood pressure? Are they not going for preventive screenings? There's a lot that can be done there. And it sounds like you have it there when you said the geographic. If they can get down to that 4-digit identifier, then that will tell them what each household on a block should look like. And then that'll be some really powerful information.
Yeah, those are the details that we need to kind of parse out when we start digging in. Absolutely.
Yeah, I'm going to defer to Director Kim because I saw her kind of raise her hand before, and she is an epidemiologist and works at the University of Illinois, so I would defer to her before I say anything.
No, I was just wondering about, you mentioned 1115 waivers, so I'm just curious, like, at this point, is there a 1115 waiver to actually reimburse Schenectady? What do you?
No, but it's still planned, despite everything.
Could you explain what 1115 waiver is?
Sure.
I'm sure there are a lot of people that don't know what 1115
We've been working
waiver
with the state of Illinois to, they applied for an 1115 waiver, which allows for Medicaid populations to reinvest in certain areas that, you know, have the premise of improving health outcomes, including social determinants of health, investment in the what's called the reentry population from jails and prisons, and some other areas. Those first two, the social determinants of health and reentry services, are the first priorities of the state. We're still moving forward. And initially, they thought implementation for the social determinants of health would start in January, but that has been delayed. So we're still kind of getting guidance from the state on when that might start. So they're not currently reimbursed, but that is the hope, that when we serve Medicaid patients through Food as Medicine and also Housing for Health, which you'll hear about next, that, you know, that'll help support the program.
And just to clarify, anytime you have a waiver, an 1115 waiver, what that's saying is the rules are normally X. We want to do Y, but we want to do it in an appropriate and approved manner, and so it has to be approved. And then some states can get extended periods of time, like the state of Texas has 1115 waivers that went through now for 10 years, but usually it's a shorter time period so that the program can judge as to whether or not these programs are creating healthier communities.
Thank you. I'd like to close with Director Harrington's question on this topic. We have 19 more programs to present, so I want to keep us on schedule, please. Thank you, Director Harrington.
Yeah, I just want to make a point that really what we're talking about is taking a look at what we're doing in two ways. One, retrospectively, because we know what we've done in the past and we know what works and what doesn't. But more importantly, what are we planning to do prospectively? And how do we know that's working? And that's why the metrics are important on both ends. And if we don't have to show that something has worked, then we'll never know. So I think what we're very concerned about is knowing what's happened in the past, what's worked, and I'm sure you know all that. And then telling us these metrics is going to use to move forward and when we can have a report. I think that's what we're really looking for ultimately.
Yep.
Thank you.
Thank you. It certainly is an important topic, and I don't mean to cut it short, but I know there's a lot of information to get through on other equally important topics. Thank you.
And next up is our Housing for Health program. The metrics that we are reporting out on today are very specific to, as you may know, these dollars were brought in to support our flexible housing pool program. Additionally, the respite program that we have on the west side, these dollars also allowed us to bring in regional partners to help with housing navigation, and we were also able to bring in a behavioral health point of contact or specialist to help address specific issues. And so these numbers specifically speak to the percent of patients who have been connected to additional health care services. Of the 1,866 points of contact, 49% of that number have been connected to additional healthcare services, primarily behavioral health. The two largest points of connection were behavioral health and primary care physicians. The percent of enrolled patients who completed the medical respite stay is at 94%, and that's 94% of 322 participants in the medical respite program. And the number receiving housing stability services, again, is close to 2,000. Most of these programs were in place prior to the ARPA funding. The ARPA funding simply allowed us to continue and to support and grow. The additional new programming that we were able to bring in was identifying, again, three community-based organizations. Those three organizations were selected based on regionality to help provide support in ways that we cannot in terms of a healthcare system. They go above and beyond in terms of beyond just pointing people in the right space and having wraparound services. They are also uniquely situated to provide financial support to people who are facing housing insecurity. And again, no differently than the Food as Medicine program, we were able to create a pro forma related to the waiver, and we were also able to shift the positions for this program to the health fund.
No questions. Thank you, Shannon, for a very thorough report. Appreciate you answering all the questions. I think we'll move on to Dr. Josh. Yep.
Thanks so much,
Officer of Public Health, Dr. Josh.
Shall try to keep my comments brief. Just wanted to start out with the preface that there are a number of ARPA projects that I'm going to review with you this morning. Nearly all of them were developed late pandemic, early post-pandemic, and were thus responsive to system gaps that we identified during the pandemic, along with internal gaps, speaking very frankly. And as such, most of the staff, all the staff that we hired through these projects represent critical public health infrastructure. Each of these slides could be its own presentation, and I'm going to do my best to distill and would also want you to be aware that I know, based on the prior conversation, you'll have a number of programmatic questions. We are planning follow-up presentations specifically related to our work in the behavioral health space. That'll be coming up in November, and in the chronic disease prevention space, probably early next year, mid-year. So we just want you to be aware of that as you consider your questions. Moving on to the first of several slides here on behavioral health-related projects. So this work for CCDPH has been ongoing for about a decade and grew really organically out of our community health assessment way back in 2015, 2016, at which we were forced to confront the reality that we didn't really have much capacity to do work in the behavioral health space. So fast forward to 2022, ARPA came along. We saw it as a huge opportunity, and we're able to bring on approximately 6 staff using this funding and did some grant making, leveraging this funding to about 24 organizations to the tune of about $21 million. And to date, as you can see from the metrics, have referred 17,000 clients to additional support services, reached over 4,000 communities, and served 60,000 individuals. Next slide is related to a project that's called a Crisis Intervention Pilot Program. I want to make the point that this program was really reconceptualized or refocused early on to look at 2 key deliverables from a task force a countywide task force co-led by the Cook County Department of Public Health and the Justice Advisory Council. This task force was conceptualized essentially to look at the crisis landscape in suburban Cook County and had 2 key recommendations. One, to conduct a workforce assessment, which I think at this point this body should be familiar with. That assessment has been concluded in collaboration with my colleagues at the Office of Behavioral Health, and the stream of work related to the recommendations from that report is going to be led by the Office of Behavioral Health going forward. We have also, CCDPH has, as a separate project, conducted its own deep dive crisis system assessment of the system in suburban Cook County. That report is forthcoming in November. And so please be on the lookout for that report. Moving on to the mental health hotline, this is another project that was, again, conceptualized post-pandemic, looking at the increasing awareness of and prevalence of behavioral health issues during the pandemic, partnered with the NAMI Chicago to expand its existing behavioral health referral system or hotline to suburban Cook County. It previously only served the city of Chicago. This project will be concluded early 2026 because we're essentially shifting the funding to Office of Behavioral Health as it's really more aligned with the work that they're doing. Next slide. Now moving on to the opioid overdose prevention space. This is the work that we've perhaps been involved with the longest. I think you've heard a lot about this work in terms of both naloxone distribution, advancing and increasing access to harm reduction services. So you can see here some of the metrics, and I'm not going to read through all of them, but just would focus on that metric, number of doses of naloxone distributed by CCDPH used in an overdose event at 64. So that's 64 doses of medication that were used to reverse an overdose and potentially save a life. I think if there are any numbers that I take pride in, it's that one. I think it's actually, going back, this number just references naloxone distributed by CCDPH using ARPA funding. If we were to look at the totality of funding, that number would more than double. I think we've seen 160 doses used across suburban Cook County. Next slide, talking about the Good Food Purchasing Program. I know there's a lot of interest in this work, and again, want to make the point that we will be presenting out to you about this in mid-2026. For those of you that are unfamiliar, the Good Food Purchasing Program is essentially a way of thinking about food systems. So if food is medicine, food systems are really public health and population health. And so essentially, getting into the details is something I don't necessarily want to do because it's sort of wonky in that it essentially uses the public sector contracting process and sort of nudging on that public sector contracting process to make changes to food systems. And does that by trying to institute the idea that we need to value local economies, so local purchasing, we need to center environmental sustainability, we need to make sure that we're being kind and compassionate to our workforce, we're considering animal welfare, and of course, nutrition. So you can sort of get an idea from those values how broad-based this work is. Again, it's kind of wonky, but some of the work that you've heard about and you've expressed interest about previously, like food waste audits that we've done at both Stroger and Provident Hospital in collaboration with my colleagues there, has come out of this Good Food Purchasing Program. A lot of good work happening here, and again, we will report out on this in more detail at future board meeting. Next slide. Moving on to Worker Protection Program. Again, I'm moving quickly here. I do want to pause and just center how important this work is in particular. At CCDPH, we've really invested a lot of time and effort in partnering with workers' centers in particular. These are essentially nonprofits. They're not unions. They're nonprofits that help workers advocate for themselves and organize. And so we put a lot of time and effort into working with worker centers and developing strategies through which they can help individuals that are engaged in precarious work to advocate for themselves. Say, for example, if there's wage theft occurring, right? You could imagine how that could adversely impact one's mental health and certainly one's physical health. And so we've managed to reach through these kinds of strategies, as well as more kind of like individual-based, hey, here's some information, or hey, during the pandemic, here's some PPE. We've managed to reach, educate, or train nearly 250,000 workers across suburban Cook County. We've had a number, 139,000 worker-led solutions instituted, as well as tracked nearly 300 violations. Again, I want to raise the example of things like wage theft here. Next slide, the Community Health Worker Project. Here, again, there's some nuance in that this stream of work was initially funded through a CDC grant. That funding flipped over to ARPA earlier this year, given the early rescission of a couple of CDC grants that we held. And so you can see some of the numbers appear small. So you can see from April through June, our small but mighty group of community health promoters provided 375 residents with educational interventions. Surely that number will grow over time. Thanks to the Office of the President and CCH leadership, we're moving some of these staff, along with a number of the other staff I referenced, onto the CCDPH corporate budget going forward. Next slide. Building healthier communities. I'd say this initiative was the initiative that most directly sprang out of concerns late pandemic about mental health, food insecurity, and issues among youth. So this was really sort of bread and butter grant making to organizations across suburban Cook County that are involved in that work, and you can see for yourselves the significant impact we've had in terms of meals served, distributed, or delivered being nearly at 1 million, nearly over 150,000 participants served, and so on. Next slide. Lead poisoning prevention, is another area that we've talked about at length here. I would just note that in this instance, we used ARPA funding to essentially top up our existing special purpose lead fund to allow us to continue to do the work of doing lead hazard remediation and abatement and so forth. And again, you can sort of see some of the numbers here for yourself. And just wanted to end with our public health emergency preparedness program. Here, I think I'm really thankful to, again, CCH leadership and the Office of the President, because we shifted a number of staff from grant funding, which was at risk. You've heard a lot about how there's been issues with the CDC budget and layoffs at CDC. It's really critical that we sustain this staff, particularly lessons learned during the pandemic and the need for a really strong public health emergency preparedness infrastructure. You can see some of the work that they've done, some of the deliverables that they've produced. Again, this is sort of wonky, but I assure you that these work products are absolutely critical. When we think about something like, for example, a continuity of operations plan under bullet 1 for new protocols and preparedness enhancements, that really is the plan that says, hey, this is how CCDPH is going to operate in the event of an emergency at a very practical sort of level. That concludes my slides. I know I moved really quickly. Happy to answer any questions that you may have. Yes.
Yeah, I don't have a question per se. What I'd like to request is, you mentioned the community health assessment. I think it'd be good to share that with the board so that they could see what the data is you've collected and how you're addressing those problems.
Thank you so much for that question. So the community health assessment is going to be the first quarter report for CCPH. So that's going to be coming in February is when we're shooting for.
Okay, great. And one other thing is, what's implied in all that's been said, and it occurred to me as I was listening, is we're not doing all this work. We're paying people to do this work. We have community partners.
It's a mix.
Yeah, and we're talking about a lot of money that's been put into the community to address these problems. And I think there's a way to actually demonstrate the investment in community numerically in terms of the dollars that have been put into the community to address these problems. It's implied in what we're talking about, but it'd be greater to see how many people have been employed as a result of this, how many people are doing this work on the ground, because we couldn't do this by ourselves. So I think we should lift up our community partners as
Thanks for lifting that up. I completely agree with you.
Sort of related question, Director Harrington. I'm a little worried because I heard CDPH actually had to let go of so many workers, including CHWs and actual CDPH members. What do you think is going to happen after ARPA money, and what are your plans to protect our public health workers?
Thanks for that question, Director Kim. So I always want to lead with gratitude here to the President's Office and to CCH leadership, because I think there's been communicated to me repeatedly a message about the value of public health, and that's not just words. There's been a concrete investment of $4 million to support 41 FTEs coming to CCDPH, largely to preserve existing ARPA, and again, not just ARPA, but at-risk grant-funded positions, along with an expansion of our lead poisoning prevention program, given some of the state changes that have been made that we've discussed previously. So I confess I do feel almost a little bit of survivor's guilt in talking about this, just looking across the country and seeing what's happening at the state and local level to health departments. I would also say just a little bit of nuance there in that the Chicago Department of Public Health is much bigger than the Cook County Department of Public Health, but they're also much more highly funded by the federal government. And so it's those federal dollars that are really at risk, and what has led to the loss of staff that you just mentioned. We're not as big, but we also weren't getting as many federal dollars.
And I think finally, touching on both of those statements, not only seeing the investment, but more particularly the return on investment.
Yep.
So for each dollar that is being spent, how much are we saving?
Yep.
Because I think sometimes we don't always see that in our equations. We see the amount of money that we've expended, but we don't see how much money that these expenditures then not only return in the positive health outcomes, but how much they're saving us because we're expending this money in the public health realm, in preventive services, in addressing social determinants of health, and then that we're actually gaining money. So for each dollar we might be spending, we might be gaining $3.50, and that some way that has to be factored into these equations as well.
Thank you for that point. I mean, I sort of take for granted that it's ethical, like doing this work is ethical, but I agree with you in that we do need to lift that up. And, the thing I always think about is for every dollar invested in influenza programs, specifically for seniors, there's a $41 return on investment. That is massive, and I think very clearly makes the case for what you're talking about. Thank you.
Thank you, Dr. Joshi. And I just want to reiterate that there will be more updates, more comprehensive updates coming in the future to the board members. So thank you for highlighting on a high level all these critical programs. We'll move to the Office of Behavioral Health under Dr. Tom Nutter, Chief Behavioral Health Officer.
Morning, Directors. Tom Nutter, Chief Behavioral Health Officer for CCH. Just three quick things from me before we dive into our Stronger Together slides. First, I want to say thank you to Jennifer Brothers and her team for the outstanding work that they've done, not only in standing up the Stronger Together program, but administering it. So here's not only Jennifer, but Sophia Kozlowski and Nora Benamar. Second, I want to address the obvious first question on this slide, which is you've spent just under $29 million. You have $75 million budgeted. Are you going to be able to spend those funds by the end of FY26? As of today, with invoices received, we're just under $34 million. And I'll remind the directors that our 53 awardees contracts were not initiated until September or October of last year. So given the current rate of spend and current plans, we do think we're going to be able to be very close, at or very close to the $75.1 million by the end of fiscal year 26. Thirdly, in a related story, when we have 53 awardees, there are going to be some who underspend a bit and some who not only do outstanding work, but spend effectively. And so in upcoming Finance Committee meetings, there'll be some requests for increasing some of those contracts for specific agencies doing particularly good work. And with that, I will yield the floor to OBH's Monitoring and Evaluation Coordinator, Nora Benamar, to talk about the impact of Stronger Together funds.
Morning, everyone. Happy Friday.
Good morning.
So the Stronger Together initiative brings together 53 partner organizations that span the behavioral health continuum. from prevention to crisis response. So the work is organized into 5 key strategies, from early prevention to crisis system enhancement, that collectively strengthen how individuals and families access behavioral health services across the county. So I'm going to walk through each strategy, highlighting key outcomes and sustainability efforts. So we're going to start off with our prevention and early intervention strategy for youth and families. This strategy promotes mental wellness, resilience, and early identification of behavioral health needs before crisis occurs. So through our 21 partner organizations, we're reaching youth in both schools and community settings, helping them build coping skills, increase emotional awareness, and connect to care early on. Since September 2024, we've served nearly 5,000 youth and 1,700 caregivers, with 3,700 screenings conducted. Of the youth we served, 91% strengthened coping and resilience, and 81% improved school outcomes. These results reinforce how early prevention can make a measurable difference in long-term well-being. Next slide, please. For adults and older adults, our focus is on early detection and intervention, identifying behavioral health concerns before they escalate. Through 10 partner organizations, we've screened over 46,000 adults and older adults, referred nearly 6,000 individuals to behavioral health services, and supported 4,100 people who showed measurable improvements in their mental and behavioral health. We've also strengthened provider capacity, especially in suicide prevention and early identification training, helping reach adults in underserved communities who might not otherwise access care. Next slide, please. Our next focus area is treatment, recovery, and support for youth and families experiencing mental health challenges or trauma. So with our 10 partner agencies, we have served 6,680 youth and families, with 67% screened and referred to care. Among those served, 40% completed treatment or support services, and 35% showed measurable improvements in their mental health and overall functioning. These services emphasize culturally responsive and trauma-informed approaches, ensuring care reflects the diverse experiences of the youth and families we serve. This is about helping families stabilize, rebuild, and ultimately thrive. Next slide. For adults and older adults, our treatment and recovery efforts focus on expanding access to care from therapy and substance use treatment to harm reduction and recovery coaching. Since September 2024, the 6 partner organizations in this strategy have served 11,984 individuals, delivering more than 1,300 therapy sessions to support engagement and continuity of care. Of those served, 49% completed treatment or recovery programs, 11% showed improved behavioral health outcomes, and 6% maintained long-term engagement in care. Many of these individuals are unhoused or disconnected from traditional healthcare systems, and these programs are helping them rebuild stability by connecting them to housing, employment, and recovery resources. Next slide, please. Finally, our crisis system enhancement strategy ensures that anyone in distress has someone to call, someone to respond, and somewhere to go. 7 partner organizations deliver a continuum of crisis response services, including living room models, mobile crisis teams, and call line supports, providing immediate trauma-informed care and reducing reliance on emergency departments. This strategy has served 1,800 clients, with 66% stabilizing after crisis. And in December, a new crisis stabilization site for adolescents will open, further strengthening this critical continuum of care. Across all strategies, sustainability is our driving focus. We're working closely with our partners to determine which Strong Together services can be billed or reimbursed through insurance, Medicaid, or Medicare, while assessing barriers, facilitators, and overall feasibility for sustaining these programs beyond ARPA funding. Additionally, our 11 regional behavioral health collaboratives are creating strong alignment and expanding access to continue these essential services long term. Any questions?
Director Robinson?
Okay. Fantastic work. I think Dr. Nutter knows I'm a fan. My concern is, and it goes also to Ms. Andrews as well, is that I think the work that you're doing is extremely crucial. The dollars we received help, but I'm concerned about the ability to move forward because your numbers indicate the importance of being able to offer the services, especially on the preventative with the youth. That was actually somewhat staggering to realize it's only been a year. And you only really scratched the surface, even if you scratched it, because I oftentimes wonder, what do people do if they don't have decent, not even to mention good insurance, but just decent? Because to understand the impact of what behavioral health is in our society now with the social media, it is something that all of us in this room, we've never experienced. And it is so prolific. I don't know any person who hasn't been touched by it. So my concern is, how do we figure out a way so that you can continue? And I love the use of the word sustainability, because I think it's most apropos in that scenario. And that becomes the great question that we need to try to solve. How do we continue to sustain it? So it's fantastic work. Standing at doing that, and having people with that level of expertise and enthusiasm, and with the team that she has, does garner some optimism, and I am congenitally morose. So I hope that's at least a little bit helpful.
Yeah, I think go off of that. Oh, sorry. Go off of that. Oh, sorry. Okay. So to go off of that, we're also maintaining transparency and keeping that communication open with our partners. So understanding where they are at all points, we're not leaving this till last minute, like we're going to have this conversation last month with the grant. We're having these conversations now. We've had these conversations since we started, and we're going to continue to have these conversations. And I think from our standpoint and from our team, big on advocacy. So like if we can find something to help them in the meanwhile, we're sending it their way. We're helping them grow what they have, so that we can sustain this. Because the goal is sustainability. We want them to grow. We want them to maintain, because the numbers are there. We're helping people. Why would we want to stop? So we're having those conversations, keeping it open, looking for them, and then helping them in the progress.
Thank you, Dr. Nutter. Nora, thank you for the presentation. Oh, sorry, Gina.
No, that's okay. I just have more of a, I guess, given what Director Harrington said about the number of community organizations, partners that we're supporting, is there a coordinated effort in how we're working with partners, especially given the infusion of dollars and that they will be going away, and that does have impacts on organizations and the populations?
I mean, coordinated effort, not per se from my end, but I think at Public Health and in TRO 11 and Office of Behavioral Health, those are the big ones where there's a lot of grant making to community organizations, and that there's been a focus there.
Great, thank you.
I have 3 to go through, and I will be quick because I'm not the subject matter expert. But can we go to the next slide, Deb? So I'm just reporting out on 3 programs that don't fit into the groups that we just heard from, additional behavioral health personnel and support at existing clinics. We've had this ARPA initiative allowed us to deploy 20 additional social workers throughout our ACHN network, and this will be critical in terms of meeting some of our value-based care metrics. One of the areas that they've been supporting that is, follow-up after a visit in the ED or inpatient to make sure we hit that 7-day or 30-day metric. So The other exciting news about this proposal in terms of, or this program in terms of sustainability is the licensed clinical social workers are able to bill. They've become credentialed in the past year and have started that we're able to bill for their work. And so we'll be assessing that. That's very new, so we'll be assessing how we're doing with that going forward. But that will help us sustain this program. Next slide. The next program is Healing Hurt People Chicago, and it is a program I think you're all familiar with, but it's providing social work assistance to help individuals impacted by trauma with recovery through various forms of intervention. We're starting the process to credential the licensed clinical social workers now so that we can also bill for their work going forward. So that will help us sustain this program in the future. Next program. So the final program here is the Youth Juvenile Justice Collaborative Expansion, which was a program funded funded through the Office of the Chief Judge. It's an ARPA program, but it gave us 2 care coordinator positions to augment the care coordination function for justice-involved youth at the JTDC. They've had some preliminary positive outcome results that, compared to a control group of individuals not receiving these interventions, that group had a 30% recidivism rate, whereas the group with some of the interventions had a much lower rate. So those are preliminary, and we'll be continuing to monitor that as like the ultimate outcome for this program. And we have folded these positions into the health fund this year and are hopeful that it will be an activity that will be covered by the pre-release portion of the waiver going forward. So happy to answer any questions.
Director Harrington.
Yes, it's really powerful to see these reports, the HEALER reports, and know that we've impacted a number of individuals. But that's my question. Is there any way to tease out how many people how many individuals we actually served, and what that cost was, what that dollar amount? It may not be, but it'd be interesting to take a look at that and see if we can see that impact on a population, because there's several different grants here. Yep. People probably have received multiple services. But what does that mean in terms of individuals who have been impacted by these reports?
I think we would be able to look at like number of individuals and by program. Where I might not be able to figure that out is if they participated in multiple programs. If
just a wish.
We'll take a look at it and see what we can come up with. Thank you.
No other questions. Andrea, thank you for the update. Appreciate it. We'll move to the Provident update, please.
Dr. Arnold Turner, Chief Hospital Executive, Provident Hospital, Cook County. Good morning, Chair Gosler, directors. Here this morning to give you an update on Provident. I brought my team along with me to share in this presentation. To my right is our Chief Nursing Officer, Michael Moonen, and sitting there is our Interim Associate Chief Hospital Executive, Victor Gaffalo. Just to give you an overview initially of Provident. Provident Hospital was the first African American-owned hospital in the United States, currently located in the historic Brownsville community. It has a very rich history, which many people are familiar with. That it's one of its founders, Dr. Daniel Hill Williams, did first heart surgery there in 1893, and also is the birthplace of former First Lady Michelle Obama. But you may not know one other outstanding physician that was at Providence Hospital, and that was Dr. Leonidas Berry. He was one of the first physicians in the United States to do GI endoscopies. He was the first physician in the United States to perform GI biopsies, endoscopic biopsies with a flexible scope. The reason for that was he invented the device that allowed physicians to do that. One of the historic facts that's associated with Providence Hospital. Providence is a community hospital. We have a 38 med-surg bed capacity. We have 6 ICU beds, 11 CTSC chairs, and 10 operating rooms. On the slide, you see our scope of services there, which I'm not going to read through. But we also, in addition to that, we have 2 clinics under the Providence license, Stack and Brownsville Health Centers. That's important because when we undergo our joint commission survey that's coming up next year, they will also be surveyed. Next slide. I'm going to hand it off to Mike Moon.
Okay. Thank you, Dr. Turner, and good morning. Thank you for the opportunity to present to you on our exceptional nursing staff and their part in supporting our strategic pillars. So who are we as a nursing staff at Providence? We have several pictures there on the left. Kind of sharing different parts of our nursing team and what they've been doing. First and foremost, we are Leapfrog Award winners. So the Leapfrog Award for 2024 certainly has significant elements that are coming from our nursing teams, and I want to raise all of them up. There's essentially an award for patient quality, and they do an exceptional job there in supporting patient safety. We're also employee engagement leaders. Nursing last year did lead the system in employee satisfaction, and Providence Nursing led all of nursing in employee satisfaction. So by my math, that's pretty good. We're also pursuers of nursing excellence. So those of you familiar know ANCC's Magnet program. They also have a program for Pathway to Excellence. We are on that road right now and feel strongly that the outcomes that I'm about to show you do put us in a position to pursue that successfully. We also are a team that helped revamp our surgical services. A lot of work went into that at the beginning of this year, end of last year, and I'm going to show some numbers that will bear the fruit of that work. And want to raise up separately also Javier Madero, part of our nursing team, who's joined us as our System Executive Director of Surgery, who has been partnering and leading some really, really great work in the surgery department. Next slide. Okay, so when it comes to safety, quality, and experience, I want to highlight 2 specific major wins from our nursing team. I do want to lead us by saying we also have had 0 Caudes collapses for 2 years and 0 Happies for a full year. So despite being small, we feel we are mighty, and they're doing an exceptional job there. These two graphs depict that. You can see the exceptional work that has been done around left without being seen. In case you're not aware, that is a leading metric among our nation's EDs, something that we watch very closely because of the impact. So that's a patient who comes to your emergency room for care and leaves before they receive it. The impact of that, a JAMA study showed that 28.4% of left without being seen patients will return to the hospital with significantly more costly care. Over the course of the last year, you can see the gray bars are the rolling 12, the blue bars are the individual 12. The strategies that our nursing team implemented, along with our provider and chair, Dr. Allegretti, want to raise him up as well. It really have driven down that rate from greater than 10% to less than 2%. The next thing I want to highlight for us here at Providence is our contribution to improving our fall rate. These are actually raw numbers. So 3 years ago, I believe we had 38 total falls for that year. First year, we took that down to 32, and this year made a very aggressive goal of 16. You can see those gray bars are the rolling number of falls that we will have, and that is 14 in case you can't see it. That is some really great progress and all done by our frontline nurses and the nursing leadership team. Some of the work that was done to improve that was following the fall must-haves that most hospitals do follow, but also employed a creative strategy on fall rooms. So we created fall rooms that are designed close to the nurses' station, and our high fall risk patients are moved to there. Next slide, please. And lastly, I'm going to speak to growth, most notably in our surgery department. So we did begin the year without an endo provider, so you could see the numbers started slowly dropping down. I think our low point was 166 cases a month. Last month, I'm happy to report that we had 275 total cases versus a monthly target of 254, so it's about 11% over budget. And the other graphs kind of highlight the work that goes into that. So in addition to getting the new endoscopist, adding gynae, adding pain, a host of other services that we are working to add at Provident, we also did improve key quality metrics. The first one is, the first two on the left, I'm sorry, are showing the completed case rate. So we want all the patients that are scheduled to have surgery to actually arrive and have those cases completed. We began that journey with a completed case rate of around 64%. You could see there that our current last rolling 5 was 90%. So exceptional work was done there. In addition, on the lower right-hand corner, you can see the on-time start rate. Again, has been a work in progress. It's never a steady stair step up the whole way out, some peaks and valleys, but some great work has been done by our teams there to get our cases to start on time and obviously keep our providers happy, keep the cases moving throughout the day, and really keep folks wanting to come back to Provident. So I believe that is my last slide. I'm going to hand off to Vic.
Congratulations on the good work.
Before we go there, may I ask a question?
Yes.
When we look at the growth surgery, this has been the object of a lot of our reports where Provident has not been meeting the metrics that we see that were outlined. So my question is, you're showing great growth. How does that impact that number?
I'm sorry, which number?
The variance to budget in terms of the volume.
Oh.
So again, as we've talked, right, it's catching up, right? It's that growth that's going to, we should be outpacing. We're hoping to get back to even by the end of the year. But, we were like 40 plus, I think 44% behind at one point.
So specifically, when I see this, the growth that's being demonstrated here with the outpatient, is this indicative that that number is reduced, or?
That 44 is going to start getting back to zero.
Okay, so we have the surgeons in place, we have the operating rooms, we've done the marketing, so now the people are coming in, so we should see, at the next report, we should see that number going down.
It should start trending into the right direction, yes.
Okay.
And again, this is budget, this is our prediction last year of where we would be, right? So that then we're off of that prediction, right?
Okay.
Yep.
Thank you for the good question. Go ahead.
Good morning. My name is Vic Alfano. I am the Interim Associate Chief Hospital Executive. Pleasure to be here today. As part of the review of transformation and growth, we have a number of projects that have been started and a number that will be completed, all looking to be done by the end of next year. Compactor replacement and the sewer work that is going to be done in March. Pharmacy renovation is underway in the design phase and will be completed in May. Heating and cooling replacement, that's been something we've been working on for over a year. We've renovated a number of our air handling units, and we have a full replacement plan in place for the coming year. Completed in June. Ambulance bay upgrade and the parking garage upgrades are slated for October. Ballistic window installation for November, and lobby and interior updates in December. Next slide, please. In 2024, along with the rest of the system, we completed the employee engagement survey. We rated 3.98, which was 37th percentile compared to the national safety net hospitals across the country. We took those results, we reported them out at our monthly managers meeting. Each department was then asked to select one of 5 questions that where we had not scored favorably relative to the national comparison hospitals. And then each month we have 2 of those people, 2 of those departments report out their activities and their findings and best practices. Next slide. In terms of fiscal resilience, the numbers there, the graph is purely to show the progress that's being made by a number of our departments. We started the year at almost 103 agency contracted employees, and over the course of the year, we have now reduced that by 40. The target was a 30% reduction, so we've exceeded that. To the point relative to the financials, that's our labor costs have, through August are approximately $5.3 million favorable to budget. So that's made a great improvement there. The challenge for us is that we continue to be, despite activities in terms of recruiting and conversion of agency to employed staff, we're still at a 29% vacancy rate. And with that, if there are no questions, I'll hand over back to Dr. Turner.
Thank you. Next slide, please. Before you, on this slide, we have the accreditations and honors that Providence received. You know that we did have a successful triennial Joint Commission survey for both the hospital and the primary care medical home. In 2023, we now have window again, and we're preparing for that survey. Along with Georgia Hospital, this year we attained the Joint Commission Health Equity Accreditation. But more recently, our Providence Dialysis Center received the IUPH accreditation. The College of American Pathologists Laboratory accreditation for our lab this year. American College of Radiology again accredited both our 3D mammography and nuclear medicine this year. And Providence was one of Becker's top 100 community hospitals in 2023. We all know that Providence received the top general hospital award last year in 2024. Providence sits on the south side of Chicago, in the community of Bronzeville. Its catchment area is predominantly African American, which has a high rate of diabetes and hypertension, which results in increased number of cardiovascular events, strokes, and other complications from those diseases, including end-stage renal disease, resulting in the need for dialysis. One of the things that we have been doing, we have been collaborating with county care to have health fairs that target patients that are out of care, to bring them into our healthcare facilities, get them in care. We've had a women's health fair, men's health fair, and a children's health fair, and a community baby shower with county care. Patients who have not been seen or are not up to date with their care are targeted by these fairs and brought in. The fairs include physical exams, chronic disease assessment, appropriate screenings based on age, vaccination, and also try to get them into follow-up appointments with the clinic, working with the county care case managers to make sure that that happens. We also participated in Commissioner Lowry's health fair that he had a few weeks ago. Next slide, please. You've been seeing that Providence has not been making budget as far as volume. We're not just to let that go by. We actually have engaged in some strategies to try to address that. One is working on to increase our average daily census. There are 2 components to our average daily census, and that's the inpatient volume and the volume in the CTSC. To increase the inpatient volume, one of the things we noticed that when we open up ambulance runs in 2022, in 2023 we were averaging over 300 ambulance runs a month, and our volume definitely peaked, increased at that time. Since that time, though, ambulance runs have fallen off to right now, I think we're averaging less than 250 ambulance runs per month. And speaking to our resource hospital on the south side, there has been, we're not the only ones that have seen that, because there's been a decrease in the region, but we are addressing that with them to see what we can find out, what we can do to improve that. One of the other things we're looking at to decrease the transfers from the Provident ED for admission to Stroger inpatient units. We're also working to establish a process so that the transfers become bidirectional, meaning that patients out of Stroger's ED are transferred to Provident inpatient units for admission. We also want to increase the primary care referrals, and that is twofold. One, we're going want to make sure that our own primary care physicians in our ambulatory care centers that are in the Provident catchment area are aware of all the services that we have to offer. And two, we're going to target some fairly qualified healthcare centers that are also in our catchment area to increase referrals there. And the other thing, we're looking to increase the number of surgery cases that require an overnight stay. With respect to the CTFC, we have revised the admission criteria to allow us to accept more patients. We've actually embedded the site of APRN in the ED, so when someone comes in with behavioral problem, they work right alongside by side with the ED physician, determine whether if it's medical or not, that it's purely behavioral, then they would initiate care and treatment there if the patient is agreeable. The other thing, working to establish liaisons with community behavioral health centers and substance use disorder treatment centers. Reason for that, as we know, a lot of the people who abuse drugs are using it to treat their own mental health disorders. And again, we're working to establish with the Stroger ED a process of transferring patients with behavioral health issues to the CTFC. Next slide.
Before we go to that slide, on these strategies, now this is fantastic work. This is absolutely, this is what we've been looking for. So what I would like, if we can, Chair, can we have a report on this, because what gets measured gets managed. And this is great. And if you can hold your people's feet to the fire, this will make the difference. You've identified the problem and you have a strategy to address it. This is fantastic. I just want to say I'm really happy to see that this is great work. This is fantastic.
Thank you. Yeah, I think that's a reasonable request. I'll just say that my sense is that there is increased primary care referral and increased surgical opportunities coming out of the FQHC industry. So I think that's a good targeted approach. Anything else?
Next slide.
Marketing Provident. Go ahead, Alice.
Thank you, Alice Millington, Chief Marketing Communications Officer. To augment the great work that the team is doing at Provident, operationally, we are also going to be promoting the hospital through a two-phase marketing campaign. The first phase is in market right now with digital ads that highlight both the services of Provident and then also its legacy, and we'll also be doing a postcard mailing in the next few weeks. Phase 2 will be a more robust omni-channel marketing campaign to really elevate awareness of Provident and incorporate events and other outreach strategies for those key partners in the region. Happy to answer any questions. Thank you.
I don't hear any or see any. Thank you. Thank you, Dr. Turner, Alex, Victor, Michael. Thank you. Appreciate the presentation.
Thank you.
Thank you.
Dr. Arnold, thank you for the history, because I thought I knew the history, but you introduced quite a few things I didn't know. Quite well.
And thank you to the directors for excellent questions and, as usual, your strong engagement. We'll move to item, let's see, where are we at? Item 8. Sorry, I lost track here. Oh, right. So the board will not be going into closed session today. So if there are no other questions or matters to discuss, we can move to adjournment of the meeting. As the agenda is exhausted, the chair declares the meeting adjourned. Thank you, and have a great weekend.